Hello, everybody. My name is Dr. Yash Bafna, and I'm from MGM Hospital, Kamoti, Navi Mumbai. My topic for the paper is MRI and MRCP with diffusion weighted imaging in evaluation of benign and malignant causes of biliary obstruction. Introduction. Biliary obstruction is a clinically significant condition characterized by impaired bile flow from the liver to duodenum, resulting in jaundice, pruritus, cholestasis, and progressive hepatic dysfunction. The etiology is broadly classified into benign and malignant. Imaging plays a central role in evaluation of biliary obstruction. Ultrasonography is typically the first-line modality because of the accessibility and cost effectiveness, but is operator dependent and has limited use. CT provides improved anatomical detail, but may still be insufficient in accurately characterizing the biliary obstruction or to distinguish the benign from the malignant causes. MRI, when combined with MRCP, has emerged a highly sensitive, non-invasive modality for comprehensive biliary evaluation. It allows a detailed visualization of the biliary tree without the need of the contrast agent and accurately delineates the level and extent of the obstruction. It has largely replaced diagnostic ERCP, which is now primarily reserved for therapeutic intervention because of the associated risk and invasive nature. Functional MRI techniques such as diffusion-weighted imaging has further enhanced diagnostic capability. DWI evaluates Brownian motion of the water molecules within the tissue and provides quantitative assessment through ADC values. Malignant lesions typically demonstrate restricted diffusion due to increased cellular density and reduced extracellular space, resulting in lower ADC values compared to benign lesion. Several studies have validated the role of ADC as a non-invasive biomarker for lesion characterization. Malignant biliary lesions consistently demonstrate lower ADC values, whereas benign conditions have exhibit high ADC values. The present study aims to validate the role of MRI with MRCP and DWI in determining the level and etiology of biliary obstruction. Additionally, it seeks to assess the diagnostic utility of ADC values in differentiating the benign from malignant causes with histopathological and ERCP correlation, thereby improving the diagnostic accuracy and optimizing the patient outcome. The aim of the study is to validate the role of MRI with MRCP and DWI in determining the level and etiology of obstruction and to assess diagnostic utility of ADC in differentiating the benign from malignant causes with histopathological and ERCP correlation. So the objectives include to determine the level of biliary obstruction and underlying etiology using MRI and MRCP, to assess the role of DWI and lesion characterization and to measure and compare the ADC values, to establish an optimal ADC cutoff value for differentiating benign and malignant causes, and to correlate the MRI findings with histopathological and ERCP diagnosis wherever possible. A study of 60 patients were taken with inclusion-exclusion criteria. Inclusion criteria includes patients presenting with clinical features of biliary obstruction, elevated serum bilirubin or alkaline phosphatase level, and patient referred to MRI for hepatobiliary system evaluation. Exclusion criteria include contraindications to MRI like pacemaker, metallic implants, or claustrophobia, poor image quality because of the motion artifacts, or patient unwilling to give your informed consent. Imaging techniques includes a patient undergoing MRI, abdomen in 1.5 or 3 Tesla. So we have the imaging protocol included axial and coronal T1 weighted imaging, axial and coronal T2 weighted imaging, stir sequences, DWI and ADC at B values of 0 and 800, MRI sequences, MRCP sequences, and post-contrast T1 weighted imaging if possible. All MRI images were reviewed by the experienced radiologist, and the following parameters were assessed: the level of obstruction, intrahepatic, hilar, or distal, etiology of the obstruction, benign or malignant, morphological features like biliary obstruction, abrupt cutoff, mass lesion, or wall thickening, and DW and corresponding ADC values were analyzed. Region of interest were placed over the lesion, avoiding necrotic or cystic areas to obtain the mean ADC values. So a total study of 60 patients were taken with 36 males and 24 females, and 46 cases were benign, while 14 cases out of them were malignant, accounting for about 76.7 and 23.3% respectively. The benign causes of biliary obstruction include choledocholithiasis, post-cholecystectomy strictures, inflammatory stricture, choledochal cyst, and Mersey syndrome. While the malignant causes includes cholangiocarcinoma, periampullary mass lesion, gallbladder carcinoma, metastatic lymph nodes, or pancreatic head carcinoma. And the amount of cases and the percentage is shown in the table and the histogram. The level of obstruction was evaluated intrahepatic to be 8 number of cases, hilar 22 cases, and distal CBD about 30 cases out of total 60 cases. Now, DWI images provides an additional functional information about the improved lesion characterization. Malignant lesion constitutes a restricted diffusion appearing hyperintense on DWI and hypointense on ADC, while the benign lesions will show facilitated diffusion. 2 cases of inflammatory strictures associated with cholangitis actually gave you demonstrated diffusion restriction, leading to a false positive interpretation, while 1 case of cholangiocarcinoma did not demonstrate a diffusion restriction, resulting in a false negative value. The ADC values of the malignant lesions was found to be in the range of 0.8 to 1.3, while for the benign lesion was found to be 1.5 into 2.5, showing that malignant lesions have a low ADC value, while the benign lesions actually have a higher ADC values. So the sensitivity of the study was 92.9%, specificity 95.7%, positive predictive value 86.7%, negative predictive value 97.8%, while accuracy was about 95%. So discussion. The present study demonstrates that MRI with MRCP combined with DWI provides a high diagnostic accuracy in evaluating biliary obstruction, particularly in differentiating benign from malignant etiologies. In our cohort, benign causes were more common than malignant one, which is consistent with previously reported clinical patterns of hepatobiliary practice. However, accurate identification of malignant obstruction remains critical because of the significant implication for prognosis and management. MRI correctly identified the level of obstruction in 96% cases and etiology in 90% cases, highlighting its superiority as a non-invasive imaging modality. Compared to the USG and CD, MRI provides a better soft tissue contrast and detailed visualization of biliary tree. MRCP alone had a sensitivity of 85.7% in detecting malignant lesion, whereas the addition of DWI increased the detection rate to 2.9%, highlighting the added diagnostic value of functional imaging over the morphology alone. These findings are consistent with the study, which is done. A key strength of the study is incorporation of DWM and quantitative ADC analysis. We observed that malignant lesion had a lower ADC values as compared to benign lesion, which was found to be statistically significant. Histopathology and ARCP correlation demonstrated strong concordance with the MRI findings, reinforcing the reliability of image-based diagnosis. However, a small number of false positive and negative cases were also observed. Overall, our findings support the combined use of MRCP and DWM as a comprehensive non-invasive diagnostic approach for biliary obstruction. The addition of ADC analysis significantly enhances the lesion characterization and helps reduce the diagnostic uncertainty, particularly in indeterminate cases. So following to the cases which we have seen, so there are a few examples of cases. This is a case of 64-year-old male with dilated CBD and pancreatic duct with focal narrowing and showing smooth tapering of the terminal CBD and upstream dilatation of the common hepatic duct, right and left hepatic duct, and cystic duct. So this when this lesion does not show any restricted diffusion, indicating the benign nature of the stricture. The ADC values was found to be very high, about 2.1 into 10 to minus 1, and ERCP examination verified the benign nature of the stricture. This is a case of 46-year-old male with showing a fairly well-defined mass lesion involving the head of the pancreas, causing abrupt cutoff with irregular shouldering and dilatation of the common bile duct, the main pancreatic duct, and resultant upstream mild intrahepatic biliary radical dilatation. It appears T1, T2 isointense, showing hyperintensity on DWI with a signal drop on ADC images. When the ADC value was calculated using the region of interest, it was found to be 0.7 into 10 to minus, signifying the lesion noted as malignant in nature. There were few hepatic metastases also seen, and ERCP and histopathological examination verified the malignant nature of the structure caused secondary to the head of the pancreas carcinoma. This is a case of 51-year-old woman with benign CBD benign structure because of the passive repeated stones. ERCP stent was noted in situ. MRCP image shows dilatation of biliary duct ending in a smooth tapering structure. T2 image shows a circumferential smooth wall thickening of the CBD. DWI shows iso intensity of the structure with no restricted diffusion, indicating it's a benign nature of the structure. The ADC values were shown to be high, ranging on the value of 2.2 into 10 to minus 1. This is actually a case of the inflammatory, this is actually post-traumatic stricture. This is a case of MRCP image shows actually ill-defined soft tissue intensity lesion involving the confluence of the common hepatic duct, right and left hepatic duct, and proximal CBD, causing the abrupt cutoff with resultant significant upstream intra and extrahepatic biliary radical dilatation and suspicion involvement of the gallbladder, likely suggestive of a Klatskin tumor. There's abrupt cutoff of the common hepatic duct. There is mild hyperintensity at the perihilar region, which was showing a signal drop or hyperintensity on the ADC value. Now, the ADC value was calculated using the region of interest to be this lesion, and it was found to be 0.8 into 10 to minus 1, which is significantly low. The patient also had a few hyperintense lesions, suggestive of satellite needles, and ERCP and histopathological examination confirmed it to be a perihilar cholangiocarcinoma with a grade 3C Klatskin tumor. So, thank you, everybody.